Thanks, Tom, and thanks for the invitation today. And I'd like to acknowledge the Ngunnawal people here. I'm a descendant of the Trawlway people in Tasmania, and I've just got a photo. I work at the Judith Lumley Centre at La Trobe, and she's really been working in this space in a long while too, and I'm going to be presenting some of her work today. So I've just put a little photo up there to acknowledge some of what we'll be talking about. So I thought, is that working? There we go. I thought today, we've only got 10 minutes, so it'll be a bit of speed talking, so I can talk fast, so tell me to slow down if I am. So I thought I'd give a bit of a summary of this enormous smoking in pregnancy review that's been going on for about 30 years that Judith started. Talk a little bit about the smoking in pregnancy trials in Indigenous communities, and then just some reflections that I've had, and I've actually ended up, I'm really pleased to see complex trauma being talked about, because that's sort of where I am at the moment. And I've got my notes because actually it's about 2 years since I've actually looked at this review, so when I got asked to come and talk about it, I thought, oh my gosh, what was in that again? So this review was actually done originally on a dot matrix printer, for those of you who were alive at that time, and we've still got those printouts. But the reason that Judith did it, the primary reason Judith did it at that time, people were still arguing whether smoking in pregnancy caused any problems. And of course, the tobacco companies, as lovely as they are, would come up with all this arguments about why the evidence, all the confounding problems of the evidence, why all the poor outcomes seen amongst babies born to women who smoke could be due to all these other factors other than smoking. So by looking at the outcomes among women, all women who smoked who were randomised to a smoking intervention and who didn't, this evidence really helped put that argument to bed quite a long time ago, and showing that even though there was only about a 6% difference in the number of women who smoked in both the intervention and the control groups, that small, comparatively modest difference has a huge impact on public health. So a big impact on reduction in infants born with low birth weight, and admissions to neonatal intensive care admissions and things like that. And the University of York has done some modelling on these outcomes and showing that if people do these interventions in the healthcare system, will save at £500 million per annum. That was about 5 years ago. So it is a big, really big difference, even though in terms of the impact on outcomes. That evidence has been used to inform loads of different guidelines, so I've just listed a few of those here. And also I should just say, while I'm here, because one of the groups that I'm on, and I'm sure lots of you are on these different groups as well, is the stillbirth CRE that Philippa's involved in. And because of the impact on stillbirth, that they have been doing a lot of work recently, and there's just a rollout of a whole lot of smoking cessation interventions and pathways that are all available on the website as well, so people can access those there. So this is a snapshot of those intervention results over 102 trials, showing, as Gillian summarised before, really big, good effects from counselling, incentives, and feedback, and borderline effects for health education and nicotine replacement therapy. But the trials involving Indigenous pregnant women, didn't show such strong effects. It's not that they don't work, it's just, there's no evidence that they don't work, it's just that there's no evidence that they do work. So this is showing that they could work, there might be no effect, or some effect. So I just wanted to talk a little bit about some of the reasons we've been thinking about over the years, and that's been covered today. I think about some of the reasons that this might be. One of the things that's been coming out of, I went from smoking into diabetes, and there's actually incredibly similar sort of characteristics coming out, seen in the qualitative research about why interventions don't work as well with Aboriginal women with diabetes as well. And there was studies showing these higher perceptions of risk, low self-efficacy, and also associations with childhood maltreatment and trauma. And there's also I think Gillian, when she was talking earlier, was talking about, why strategies that involve fear don't work as well, and there's this extended parallel process model that is a theory that helps to explain why that might be the case. And the other thing that has sort of come out a lot more about why interventions might not work well in some populations as in others is that strategies that require a lot of that individual agency are less likely to be effective for people if they have less of efficacy. And there's been quite a few reviews and things like that. And so the argument is then that sometimes these interventions that rely on a lot of individual agency can have an overall effect on increasing health inequalities rather than decreasing them because they don't work as well among some people. So that's a bit of a snapshot of what everybody's already talked about today, so I get to talk about what I think is the more interesting bit. We're learning a lot more now, I think, with the emerging evidence around complex trauma about all the convergence of risk factors that happen in the perinatal period. Not only are there all these things going on around a person's life during pregnancy, we're also starting to understand that there's physiological and hormonal changes that happen in pregnancy that actually heighten people's fear and cortisol responses, and it is a protective mechanism. If you think about nature wanting to protect the baby coming into the world, and so having a naturally heightened fear response during that time is a good thing. But it does have some other, if it's not managed, it can have some other, can make things tougher as well. There's all these pre-existing vulnerabilities that can affect women at this time, to do with pre-existing mental illness that can be exacerbated, historical trauma, housing factors, all the socio-ecological things that you talked about earlier. There's actually increased risk of family violence. There's a whole lot of reasons why childhood trauma can be triggered during pregnancy. So even if people have, have been able to manage their trauma or not experiencing the effects of distress up until the pregnancy, during the time of pregnancy and when coming into pregnancy care, a lot of that stuff can be triggered. There's also the issues about previous birth trauma, sleep deprivation, all those kind of things. I don't know why I'm so nervous. It's a little bit insane. We could talk for an hour about complex trauma today. It is a really important issue. The World Health Organisation have just recognised it in the most recent edition of the ICD-11. And most of us know about PTSD, which is the sense of threat, avoidance and re-experiencing. But the additional constructs that are part of complex PTSD that's been recently recognised is these relational disturbances, having this negative self-concept, and also having what they call affect dysregulation, which is trouble regulating emotions. From an epidemiological perspective, I think the evidence is overwhelming that it's real, that historical trauma, complex trauma has a huge effect on our health. There's been some English modelling done by Bellis and colleagues in the UK that estimate that 23% of smoking nationally could be attributed to child abuse in the UK. And some colleagues, Swanton colleagues, did some modelling saying that the effects of child maltreatment actually outweighed the effects of poverty in many of these risk behaviours, including smoking. So this is the project that's been keeping me busy for the last couple of years. Well, I haven't looked at the smoking review. So we've been working on a co-design project with a whole load of people. This is an absolutely massive project. It's a 4-year Lowitja Institute and National Health and Medical Research Council funded project, doing a lot of really large evidence reviews that are as large as the smoking review, and talking with communities and doing qualitative research and pulling that together. And the key themes that are coming out of it that I think are really strong, that are really important for parents experiencing complex trauma, and this is internationally and also for women here. Fostering empowerment that we've heard a lot about today. The importance of self-care strategies, having strategies to regulate feelings of distress. I think the importance of compassionate care and support we just can't emphasise strongly enough in the context of trauma. Giving people the enabling building of connections between people, parent education and opportunities to develop skills. So that's around developing self-efficacy, and I'm trying to think of the word. I know Ray talks about it a lot. Executive functioning is really important with complex trauma. Practical assistance, housing, life skills, reducing isolation, and a range of healing and therapeutic approaches. And that's not, there's a lot of evidence that counselling can be helpful, but it's not the only therapeutic approach that can be helpful in the context of trauma because it's a physical response. So physical strategies, diet, exercise, and a whole load of other things are really important. So just in summary, in implications, there's no evidence that individual support interventions are not effective, so I do think that's an important component of a comprehensive strategy. But I agree with all the earlier people saying that we need to continue this comprehensive approach, a strong focus on structural strategies. And Sandra Eads led this work, I was helping her with it a few years ago, where we sort of outlined, I think, just really reinforcing the importance of bringing together all of the National Tobacco Strategy recommendations and the NATSIP strategies, and pulling that together in a strong way. So, it's nearly time. I'll actually get that done in time, I can't believe it. So thank you, it's been really beautiful.